Okay. Okay, we'll get started. Okay, so thank you all for being here. This is a webinar that is being presented by the Female Scientific Oncofertility Consortium Committee, or the Female Scientific Committee of the Oncofertility Consortium. And today we have with us Dr. Mario Leitao, who is going to speak to us about uterine transposition as a novel procedure to preserve fertility in young women with pelvic cancers. Dr. Leitao is the director of Gynecologic Oncology Fellowship Program and the Minimal Access and Robotic Surgery Program at Cornell Medical College within the Department of Surgery. So we will listen to the presentation, which will be approximately about 40 minutes, and then I will open up the floor to questions. You may place your questions in the chat as Dr. Leitao is presenting, and I can speak them verbally for you, or you can come off of mute when the time comes. So if you could all mute your devices, it looks like they are, we will have Dr. Leitao start. Welcome, and thank you so much.
Thank you. Thank you for the invitation. This is great. Thank you all for attending, and hopefully this is useful to you. I'm very excited about this presentation. Certain things we do in our career makes us very excited. This is one of those things, so I'm happy to share this with you all. All right, so I'm going to speak about uterine transposition, which is something that's very new that we've been doing for women who have pelvic cancers that will require radiation therapy. So my disclosures, nothing's really all that pertinent to this. So as just the background here, and I think many of you know this, that the standard pelvic radiation doses that we give for women with pelvic malignancies who are adults, again, we're speaking about adult cancer patients. These aren't patients who have childhood cancers, but the standard pelvic curative doses to the pelvis for most of the pelvic cancers we treat, such as rectal, anal cancers, as well as our gynecologic cancers and some pelvic sarcomas, is at least 45 gray. And if you look at sort of the tissue tolerances over a lifetime, obviously the ovary is the most sensitive organ. And you can see here that in a fractionated dose, which is how we give these radiation treatments, the ovary after about 6 to 10 gray is basically sterilized and no longer functional. You know, what you don't notice here is the uterus. There's very little information and knowledge about what the uterine and cervical tolerated doses are over a lifetime. So giving pelvic radiation in women who are still premenopausal is becoming more commonplace because more cancer being diagnosed earlier on. And many of these women have yet to have children oftentimes, or want more children than the ones they have. So of course, we've been trying to do as much as we can to try to preserve fertility in these young women. Because nowadays, especially for many of these cancers, there are long-term survivors. And again, here, ovarian function and exposure to radiation therapy, you can see here is very, it results in a sterilizing dose. And of course, this dose is related to the age at which a patient gets radiated. And the older the patient is actually, and this is not old, this is old in terms of biological ages of the ovary, that the lower radiation dose is needed to actually affect a sterilization of the ovaries. So because of this, what we've been doing here for many years is at least an ovarian transposition. This is something that was actually initially described from Sloan Kettering, where I work, in the 1970s via an open approach, of course. There was no such thing as laparoscopy, at least in the hands of GU oncologists back then. And this is the way it was initially described, this paper from the 1990s. And essentially, the idea was that you would try to separate the ovary from the uterovarian ligament and then be able to stretch the ovary and maintain the ovary attached to the fallopian tube. Now, I don't know whose fallopian tube this is, but this is not, I've never seen a fallopian tube this long. And of course, that's been a problem with maintaining the fallopian tube intact, is that you really cannot get the ovary out enough of the pelvis for the radiation field. And that's been a huge limitation from doing it this way. And you can see here from this paper, at least, where the ovaries are sitting. I mean, this is still within the pelvic inlet. This is still within the radiation fields for most pelvic cancers, especially those cancers that require radiation of the nodal basins, which is where these ovary clips are right now. So for rectal, anal cancers, any gynecologic cancer, these ovaries will still be in the radiation field. Here, there's another description also that describes sort of this tunneling of the ovarian pedicle to put the ovary up higher. All these methods that were described before had relatively not the highest success rates, and I think for a couple reasons. One, the ones who kept the fallopian tube intact, you limit how far up out of the radiation field you can go with the ovaries. And then these here requires extensive dissection. I think this compromised vascular blood supply when you try to extensively dissect and tunnel things for these procedures, at least for an ovarian transposition. And if you look over the years, you can see these are small numbers. There's no prospective trials in any of what I'm going to talk about today. Forget about it. There's no randomized data either, so forget about that. So this is all retrospective, sort of small series. You're talking about a relatively small cohort of young women who are getting radiation and trying to preserve fertility or ovarian function. And here, the overall rate varied from ovarian function preservation after ovarian transposition, and the average is about 64%. So this fell out of favor in many places, and we actually hadn't been doing too much of this here either for at least the non-gynecologic cancers. We were transposing ovaries for cervical cancer at the time of radical hysterectomy, though. And so many places don't even offer this yet. They just feel you just radiate the pelvis and give them hormones, and that should be fine. That assumes that hormone replacement is the same as natural ovarian function, but that might be the case, but we've never, that's the problem. We've never done a randomized trial to compare natural ovarian function from ovarian transposition versus hormone replacement in these young women. So now the way we've done it is for many years, and we published on this for at least ovarian transpositions, we actually transect the tube. Not only do we transect the tube, we actually now remove the tube because of the tubal theory for ovarian carcinoma. So we actually remove the entire tube. That gives us the ovary on a ginormous pedicle. We can take it all the way up high, take it up to the rib cage if you really wanted to, but we put it well above the radiation fields for most pelvic cancers. And we do put little clips around here, and you can see here on the right, this is one of my cases here where the ovaries are here. We put clips, a couple clips around so that the radiation oncologist can contour them out of the radiation field. Here's from one of our radiation oncologists that I started doing this years ago. These are radiation fields from a mutual patient. Dr. Goodman is no longer here with us. She's chief of radiation oncology somewhere else. I can't remember right now, but. And this is how they contour the ovaries when they give their radiation doses for pelvic cancers, and this is for a rectal cancer patient. And here's the isodose lines. And for those of you who don't do this all the time, the radiation oncologists and their physicists will plan out the highest dose of radiation to the primary tumor and then the lymphatics. So, and then there is no such thing as perfect control radiation. So what you get is these sort of isodose lines, which estimate the amount of radiation received within these fields. And you can see here what the percentages of the original dose is. And here above this red line is where you get less than 5% of the dose of radiation being given to the central pelvis. And you can see here this patient of ours with the left ovary and the right ovary are depicted here with the clips around it, and they've highlighted it with their sort of computer systems. Now, less than 55% is not zero either. And so that means there's never such thing as zero scattered to the ovaries, no matter how high we go. And that will explain some of the outcomes we have seen with our approach. And here's our results that we published a while back now. In total, we had, again, a similar sort of preservation of ovarian function, which we measured by resumption of menses and or hormonal levels. It was about 70%. But what we've noticed is in women who are less than 40, there was 90% retained ovarian function with resumption of menses actually after the radiation. Whereas if you're older than 40, only about 40% have maintained ovarian function. This goes along with sort of biological age of the ovary. But 40% is low, but it's not zero either. So we do counsel patients. We tell them that we preferentially prefer this. We preferentially offer this to patients who are less than 40. But in discussion with someone who's older than 40 and they still wish to proceed, we would be willing to do that, but we're not less enthusiastic in that situation. So this is just ovarian transposition alone. This is purely done for maintaining hormonal function. This has nothing to do with preserving fertility whatsoever because the uterus is left in situ and it is being radiated. And again, like I said, the limitations of an ovarian transposition, again, is that the tubes are transected and removed. There's no spontaneous pregnancy, although Dr. Chapman, who's here at Cornell, just told me the other day when I was at a meeting with him that there's no such thing as spontaneous, I guess. Some event happened to make somebody pregnant. So, there was no pregnancy unassisted. I don't know, whatever, you all know what I mean. There have been case reports of women who have received radiation therapies as adult, but these are small super case reports. And again, the uterus is radiated when we just do an ovarian transposition, as you would all know. The outcomes of pregnancy and neonatal outcomes after radiation therapy, almost all are from data. These are usually either single institution, multi-center, or national database analyses, and they're all mostly from childhood cancer survivors. Women who had lymphomas or other cancers during their childhood and then received some form of radiation, and it varies anywhere from pelvic irradiation to cranial-spinal irradiation to total body irradiation so the radiation fields are all very different. But what we've noticed here, even in women who are younger, who could probably tolerate more radiation, there is associated risks when they have gotten pregnant, including increased risk of preterm delivery, low birth weight, small for gestational age, increased rates of miscarriage, et cetera, and so on. And again, this is from women who receive radiation as a child. None of this speaks to women who receive radiation as an adult. And there's very little data to almost no data that's of value in sort of an adult woman who's gotten radiation. And there have been studies also in these same childhood cancer survivors in terms of uterine volume and exposure to prior radiation therapy. And in this study of about 100 patients who had at least a year after the radiation had uterine volumes measured, there was 4 groups. Group 1 had no radiation exposure, had chemotherapy for their cancers. Group 2 had radiation above the diaphragm. Group 3 had radiation below the diaphragm, but not affecting the uterus or directly in the area of the uterus. And group 4 were patients who got uterine irradiation as part of the radiation, including those who had total body irradiation, abdominal radiation, including the pelvis or pelvic irradiation alone. And what was noted here is that there's a significant decrease in the uterine volume in all 3 of these groups from group 1 to 4, but the lowest uterine volume noted is in group 4. Of course, this doesn't tell me what this means clinically, but there is some effect on the uterine volume and normal growth, if you will, or development in women who receive radiation as a child. This is a mouse experiment, which was recently published. Again, I applaud the efforts now because we need more data in this area. There's very little data, including animal data. But in this, we actually tried to do some here and just couldn't find the funding to do it. But anyhow, this was a nice sort of initial study using mice, where mice were given, there were control mice, and there were mice who were exposed or treated with radiation of 7 gray to the pelvis. And what you see here is that the irradiated uteri, when the uterus were removed, were much smaller, and at the uterine weight, again, confirming the study I just showed you in humans or in adults, is that the uterine volume is significantly lower than those who were not radiated. Additionally, there is much slower to almost no viable implantation sites in the mice that were radiated versus not, and this included in mice who were radiated, but the uterus was shielded. Additionally, there was, and going along with the lack of viable implantation sites, that there was a much higher rate of resorbing implantation sites in mice who had been radiated in the uterus. So there's definitely an effect of the radiation on the uterus. We really haven't really well quantified it yet. If you look at some guidances out there that I was able to pull, and you guys might be even more expert with this here, but in terms of sort of fertility preservation, there is guidelines out there, and there's all kinds of things to do, and measuring the using ultrasound to assess uterine volume, endometrial thickness, all kinds of things that are proposed with no data really, but that are proposed to assess for uterine functionality. But what most guidelines say is that if you received whole pelvic radiation of 45 gray or more than 25 if you were a child when you got radiation, that they discourage pregnancy. Again, this applies to every single adult patient who gets radiation for adult cancers in the pelvis. Every cancer curative dose is at least 45 gray, and oftentimes higher than that. So along comes my friend Dr. Ribeiro from Brazil, who is right here on the second from the right, I guess, the way you're looking at this. I have a very close collaboration with my Brazilian GYN oncologist. I'm actually Portuguese as my background, and I'm a member of the Surgical Society. So in 2017, this is us at a surgical live meeting down in Brazil a few years ago. In 2017, our national meeting, he presented, without telling me, this whole procedure called the uterine transposition. He then published the first case report of the technique in 2017, and actually in Fertility and Sterility Journal. And the first thing I thought is, why didn't I think of it? There are some things that are so simple that it just why didn't I think of this? It's these simple concepts that it just takes somebody to think about it, and then you're like, wow, this is just makes sense. And the way they describe this procedure, at least in Brazil, although they've modified this over time, we're close, we stay in touch all the time, is you can see here from this paper on the top left, you basically, now keep in mind that we've been doing, as a background, for cervical cancer, we've been doing radical trachelectomies for many years now. There's where we actually do a radical dissection of the pelvis. We amputate the cervix with the tumor off the uterus. We then percoclage and reanastomose the uterus back to the vagina. That's a common procedure for us now. This is actually a simpler procedure compared to that. And we've had lots of pregnancies from that approach. So this just makes a lot of sense to do. And it actually technically is easier than what we've been doing for cervical cancer uterine preservation. And so what you do here is you basically take all the steps of a hysterectomy, except you maintain the infundibulal pelvic ligament, the ovarian ligament. That's where the blood supply to the entire uterus is going to be. But you do the steps of a hysterectomy. You take the uterine vessels all the way down to the level of the vagina. You do your colpotomy, and here on the bottom left, you see the uterus with the ovaries and fallopian tube and cervix that have now been transected off of the vagina. You are now looking up into the abdomen, and the ovarian pedicles on either side is providing all the blood supply to this organ now. The way they did it initially, the way they described it, is that they actually anastomosed the cervix into the umbilicus, as you can see here on the right. That's the way they originally described this. The cervical umbilical anastomosis is the way they described it. Some people are still doing it. I can tell you that my friend Dr. Ribeiro is, I don't think, doing it any longer, but here it is. You have your menses through your belly button. I don't know, just when I heard him describe it, though, I'm like, that just seems weird. So the whole time your uterus is in place, you have a menstrual cycle through your umbilicus. So some of the pros are that you can assess if the uterus is functioning. If you're having a menses once a month through your umbilicus, then your ovaries and uterus are working. And you don't need to do ovarian suppression because there's no concern of menstrual blood flow into the peritoneal cavity. The cons, though, of this approach is that it requires much more dissection at the initial and subsequent surgeries to both dissect into the umbilicus, suture into the umbilicus, and to take it down from the umbilicus. And you have your period through your belly button. I don't know. I don't know. Anyway, I guess people have different opinions on that. So what we did when we did our first one, this is actually a picture from our first case that we did here. We decided to just give patient Lupron and keep the uterus, cervix, everything inside the abdomen. So this is a picture at the end of the procedure. We did it robotically. It takes 6 small incisions here. This incision at the umbilical area is just so that we can look upwards to anastomose the uterus to the upper abdomen. It actually the cervix sits at the umbilicus, which is this arrow here. And then the ovaries are on either side here, marked by the X's, and the uterine fundus is at the falciform ligament of the liver, actually. And this is where the uterus sits once we're completed. And the cervix is within the abdomen. Oh, there's the cervix. Fundus, ovary left, ovary right. We do give ICG, indocyanine green, which is a fluorophobe. IV to look for flow. We use it a lot for a lot of things in oncology, including looking for flow, for flaps and other things. And you can see here flow into the uterine fundus. The cervix never has flow. The body just spasm of the vessels going into the cervix that down into the bottom, but it never is translated into a problem so far. And then on the right side, you can see here the cervix attached to the anterior abdominal wall at the level of the umbilicus. And here's a CT scan on a patient because these patients have rectal cancer are getting scans. And here's the uterus sitting with the cervix at the level of the umbilicus, the fundus above and above that, obviously. And you can see that's where it sits. So I have some videos here that my partner, Dr. Mueller, put together, and myself. Dr. Mueller and I are the only two performing this here. You know, I'm not going to go over how we instituted the whole program here from a logistics standpoint. There's a lot of work to that also. I'm happy to describe that to anybody if you want to, but I don't think as pertinent to this group. And I'll probably fast forward through some of this. It is narrated by Dr. Mueller.
The technique of uterine transposition. In this video, we will review the steps of uterine transposition with emphasis placed on robotic trocar placement and docking, how to optimize organ manipulation and tissue handling, and our pearls for successful perioperative management. The patient is a 27-year-old woman with a T2 node-positive rectal cancer shown here. Preoperative imaging, including CT and MRI, revealed this to be a mid to low rectal lesion without obvious extramural extension and multiple suspicious appearing right internal iliac and obturator lymph nodes. The uterus measured 10 centimeters in size, and pelvis was unremarkable in appearance otherwise. The patient underwent neoadjuvant chemotherapy and was recommended for radiation to the pelvis. She desired fertility preservation with ovary and uterine preservation. She had previously undergone oocyte retrieval with her reproductive endocrinologist. This is a new surgical procedure with limited information regarding outcomes. Although this is evolving over time, our initial preferred patient selection includes patients under age 40 with a BMI under 35, a uterus 12 centimeters or less in size without significant leiomyomata, no obvious evidence of extensive endometriosis. The rectal tumor does not appear to involve the uterus, cervix, vagina, or ovaries, and the colorectal care team has approved or cleared the patient for the procedure. We recommend thoroughly counseling patients as to the known risks and benefits and to disclose this is a new procedure. Ongoing multidisciplinary communication to support the patient is also important. Key stakeholders include colorectal surgery, radiation oncology, fertility specialists, social work, and radiology. We prefer an optical entry into the abdomen at the umbilicus. The robotic instrument ports are then placed 8 to 10 centimeters apart to avoid instrument collision during the case, and the trocar at the umbilicus is replaced with a robot port. For instruments, we prefer the monopolar scissors in the right arm, the Maryland bipolar in the left arm, and a ProGrasp in the fourth arm. A bedside assist port is placed in the left upper quadrant, which allows for passing suture during the case, and should be an 8 millimeter, upwards of 12 millimeter in size, depending on port availability. A midline suprapubic trocar is placed, which will be used later in the case for the camera port during the upper abdominal portion of the procedure. A uterine manipulator is placed to move the uterus during the procedure, which minimizes tissue handling of the uterine cornu and adnexa. The retroperitoneum is entered lateral and parallel to the infundibulopelvic or IP ligament, leaving sufficient peritoneum attached, which helps the surgeon avoid grasping or clamping the ovarian artery and vein during this part of the procedure. The IP ligament is skeletonized cephalad to just above the pelvic brim, with careful attention to the course of the ureter, the ascending colon, and the IP ligament itself to avoid inadvertent damage to key structures. The goal is for the IP ligaments to be sufficiently mobilized to allow for a tension-free transposition of the uterus to just above the umbilicus. There will be a variation in this distance for individual patients, so after completing this step, there may be need for additional mobilization once the colpotomy is complete and the surgeon is able to better assess this. The posterior leaf of the broad ligament is taken down to skeletonize the uterine artery. This is a key step in the procedure as it enables the surgeon to clearly identify the uterine vessels and to cauterize them as low as possible to preserve as much of the collateral blood supply to the uterus. The round ligament is transected far lateral as compared with a simple hysterectomy. This provides a structure to grasp and use for traction, countertraction maneuvers. The bladder flap is created in the same manner as with a simple hysterectomy. The goal is to skeletonize the uterine vessels as low as possible, preserving collateral blood supply, which in turn can improve perfusion of the organ during the time it is transposed above the umbilicus, and potentially improve perfusion once it is reanastomosed to the vagina. Unlike a simple hysterectomy for other indications, it is very important to take care and avoid over-cauterizing adjacent tissue or over-cauterizing the uterine pedicle during this portion of the procedure. These steps are repeated on the contralateral side, skeletonizing the IP ligament to just above the level of the pelvic brim, skeletonizing the uterine vessels posteriorly as low as possible, transecting the round ligament, completing the bladder flap, and isolating the uterine vessels at or below the cervicovaginal junction anteriorly in order to ligate the uterine vessels as low as possible. Colpotomy is performed, and at this point, the uterine manipulator is very helpful as it allows for more accurate colpotomy. It is important to perform this step of the procedure and leave healthy, vital vaginal tissue to approximate. These patients go on to radiotherapy within a short window of time. The vaginal cuff is closed with a running 0 PDS barbed suture. The robot is docked for upper abdominal surgery. We prefer right-sided docking. The assist port remains in the same position in the patient's left upper quadrant. The camera is placed at the midline suprapubic trocar. The fenestrated bipolar is to the immediate left of the camera, and ProGrasp is in the far left trocar. The monopolar scissors are right of the camera. This is if any further IP skeletonization is required. If ready for suturing the organ, needle drivers replace the monopolar scissors and the fenestrated bipolar instrument. The uterus is guided to the upper abdomen, avoiding torsion. The uterus is transposed high enough that the cervix will be level to the umbilicus once it's sutured in place. At this point, we reduce peritoneal insufflation to 8 or 10 millimeters of mercury in order to reduce tension on the IP ligaments. For this portion of the surgery, we use 2-0 monocryl barbed suture on an SH needle throughout. In this patient's case, the uterus is first sutured to the abdominal wall using the right and left round ligaments, although surgeons may suture the uterus at the fundus first as well. The fundus is sutured in place, then each of the ovaries. It is important to exercise care at this step to keep these organs from torsing or imposing undue tension. 4 milligrams of indocyanine green is given IV to assess organ perfusion. The ICG comes as 25 milligrams of powder mixed with 10 cc's of sterile water for a final concentration of 2.5 milligrams per milliliter. Using near-infrared imaging, there is excellent perfusion of the entire fundus and bilateral adnexa. In our experience, the lower portion of the cervix will appear less well perfused, but has not thus far shown any long-term compromise. The peritoneum of the IP ligaments can be sutured to minimize risk of vessel torsion. The cervix is the final region sutured in place. We administer preoperative Lupron for menstrual suppression in order to avoid the need to bring the cervix through the umbilicus. Doppler ultrasound assessment at 1 week showed normal flow to the uterus and both ovaries. Radiation treatment was initiated 4 weeks postoperatively without incident. The timing of reconnecting the uterus to the vagina is based on the need for a rectal surgery procedure. We typically discharge patients from the hospital on the same day of this procedure. It is our current practice to give 28 days of prophylactic Lovenox to reduce risk of organ clot and 1 week of an oral antibiotic to reduce risk of infection. We have patients return 1 to 2 weeks after surgery for a Doppler ultrasound to assess uterine perfusion. We are not certain if these components of care are best, but do it to optimize care for best outcomes until we have more experience.
So that's the first part, and then
This is a surgical teaching.
so this is we can either do the anastomosis, the takedown after radiation. It can be done within 6 weeks of the radiation being completed. It can be done as a standalone procedure if there is no planned rectal surgery or other surgery, or it is coordinated with at the time of a colorectal procedure. This is one of our cases that with Dr. Weiser, one of our colorectal surgeons, where we do the uterine reanastomosis robotically at the same time as a robotic bone anterior resection. I'm gonna probably scroll through a lot of this video because a big portion of it is the anterior resection technique. These videos are shown at the American College of Surgeons, so these are very specific for technique based. So I'm gonna.
This is a surgical teaching video demonstrating the technique of robot-assisted uterine anastomosis in combination with low anterior resection. In this video, we will review the key steps of both surgeries, emphasize robot trocar placement and docking, demonstrate optimal organ manipulation and tissue handling, and include key operative modifications and pearls for successful perioperative management. It is important to mention that this is a video illustrating a new surgical procedure. As we gain more experience, the steps described in this video may evolve over time. The patient is a 27-year-old woman with a T2 node-positive rectal cancer shown here. The patient in a prior teaching video surgical procedure.
We got
The
this.
patient underwent induction chemotherapy, uterine transposition, followed by radiation to the pelvis. The patient exhibited a complete radiologic response following radiation, and non-operative management versus low anterior resection was discussed. She opted for surgery, and a combined low anterior resection with uterine anastomosis was planned. We recommend the gynecologic and colorectal surgical teams discuss port placement in the operating room. The first stage of this procedure is to take the uterus down from the anterior abdominal wall. We enter the abdomen using an optical entry technique using a midline suprapubic location, and later replace the optical trocar with a robot trocar for the camera. We place the prograsp in the far right arm, the monopolar scissors in the near right arm, the Maryland bipolar in the left arm, and an 8mm assist port in the patient's right upper quadrant. Adhesions between the uterus and ovaries and surrounding structures are addressed. In this case, filmy adhesions between the uterus and the omentum were taken down with a combination of cold scissors and cautery. Loops of small intestine are carefully separated and unwound from the infundibulopelvic, or IP, ligaments, making sure the uterus and ovaries are free from any surrounding structures. Next, the transposition stitches and surrounding scar tissue anchoring the uterus and ovaries to the anterior abdominal wall are taken down. At the time of uterine transposition, stitches were placed at the uterine fundus, cervix, bilateral ovaries, and round ligaments, as well as the peritoneum near to the IP ligaments. This must be done with care to avoid an inadvertent injury to critical gynecologic structures, such as the fallopian tubes and ovarian blood supply, as well as the nearby intestines. We do this to ensure no adhesions are present that could interfere with the colorectal portion of the surgery, and to facilitate safe dissection around the left ovarian vascular pedicle. It is important to orient the colorectal surgical team to the location and appearance of the now freely mobile gynecologic anatomy to prevent vascular torsion or organ injury during the remainder of the case. At this point, the colorectal team begins their procedure, starting with vascular pedicle ligation and splenic flexure mobilization. The 8 patients right is placed on tension, and the peritoneum is scored at the level. Note the ovarian blood supply within the operative view and the care required to work around this key vascular
I
pedicle.
mean, the key part to this is the working closely with the colorectal surgeons so that they are cognizant of the uterus and to make sure they don't torse it or flip it around as they're doing their procedure. So that's basically what this is all showing. It's also showing the low anterior resection steps, which
It is also
are not
important
as
to
important
section
for
or
us right
injury
now. That's how they do a roll rectal, yes.
tissue. Action is and the lesser vessel sealer device is with the pelvic portion of the procedure and arm. To facilitate this exposure, a 4x8 gauntlet.
This is just more the low rectal.
At this
So
point,
this is sort of getting
intraoperative
close to
endoscopy
finishing the
is
low
used
rectal
to assess
procedure.
best location and type of anastomosis. During the perineal phase of the procedure, ligate between the colon, treated bipolar and fill adhesion, place the organ in the pelvis. The organ is assessed for perfusion prior to attachment to the vagina.
Let's get back a little bit. I skipped over.
Arm and the prograsp in the far right arm for this portion of the surgery.
It shows the
The uterus is
anastomosis now
moved
back.
carefully via the 2 assist ports with bowel graspers on the round ligaments and a fundal adhesion remnant to place the organ in the pelvis. The organ is assessed for perfusion prior to attachment to the vagina. 4 milligrams of indocyanine green is given IV using a concentration of 2.5 milligrams ICG per ml sterile water to assess organ perfusion. Using near-infrared image.
So it's interesting that the initial surgery, the cervix didn't take up any of the dye, but probably just from spasm of those vessels, we think. We're not sure. A lot of this is we're just learning as we go, but you can see here clear there's the ICG and flow to the cervix at this point. What you did notice though is there's a sort of an adhesive sort of covering of the cervix that happens with all of our cases.
There's excellent perfusion of the fundus, cervix, and bilateral adnexa. A probe is placed in the vagina to visualize location for a vaginotomy. The bladder is dissected further as needed to facilitate anastomosis suture placement. The vaginotomy is made to easily accommodate the cervix. In this patient's case, a small amount of old blood was overlying the cervix. This was incised and the blood removed, leaving healthy cervical tissue exposed. The cervix is grasped with a ring forceps and pulled past the vaginotomy, then sutured to the tissue of the upper cervix using 0 PDS barbed suture. This is done in a running fashion, first along the anterior cervical-vaginal junction, and then posterior. The goal is to approximate the upper cervix and vagina with minimal gaps at the lateral aspects of the anastomosis. It is important to avoid excess suturing, particularly at the lateral edges where collateral vessels may have formed, to provide vascular support to the uterus. The round ligaments are secured to anterior abdominal wall peritoneum using 3-0 barbed monocryl. The ovarian vascular pedicles are checked for any twisting or kinking, and then pexied to the psoas muscle using 3-0 barbed monocryl. ICG is given intravenously once more to reassess perfusion now that the uterus is reattached to the vagina and excellent organ perfusion is again noted. Drain is placed in the pelvis. A loop of distal ileum is brought up to the anterior abdominal wall for the creation of a protective ileostomy.
Anyway, that's just showing the diverting ileostomy that the colorectal guys did. So that's the procedure. This again, we do a post-operative ultrasound. Again, many of the things that are mentioned, just to re-say what was said, is that we are doing these things. It's a novel procedure. I have no idea if 28 days of Lovenox or Eliquis is needed. I have no idea if a week of antibiotics makes a difference, to be honest with you. These are things that we'll learn over time as to the value, but we're trying to do as much as we can to be hopefully as successful as we can. So our method, again, as you saw, is to keep the cervix intraperitoneal, and we do as we just showed you. I don't have to rehash all this. So, there's now obviously emerging data. Dr. Leitao, in 2022, which is 5 years after his initial description of this at our meeting, this was at our International Gynecologic Cancer Society, presented the initial results of a prospective feasibility study that he had done. And basically, these were 10 cases over 2 years. These were his exclusion criteria and inclusion criteria. Basically, he had 8 patients in this analysis of this initial prospective quote-unquote feasibility study. 11 had been approached, and 3 declined participation. 6 of the 7 were able to preserve their uterus, meaning that they had normal menses, hormonal levels, and endometrium. 1 patient of the 7, however, died from her disease 4 months after the uterine transposition. There was 1 uterine necrosis at the 4th post-op day, which they then decided to do a hysterectomy and remove the ovary. So patients are closely counseled every time we do this, that we honestly can't give them a large number of quotes or solid quotes as to risks, but we do quote them the possibility of loss of the uterus and or ovaries either during or after the procedure at some point for any particular reason. We also make it very clear that this is a new procedure and we are learning as we go. Dr. Leitao has had the first 2 full-term live births in the world. He showed this at our international meeting a year and a half ago. These were both spontaneously conceived, meaning no assisted technology necessary, and they were both born full-term 37 and 38 weeks. We are recommending cesarean section at 38 to 39 weeks so that we can avoid delivery through the vaginal delivery. And the only concern we have with that is that the pelvis has been radiated, including the vaginal tissues, anal tissues. We don't know what the extentability is of the pelvis after radiation, but also if patient gets an episiotomy or some sort of other tear, healing is going to be a concern, and we're concerned about the risks of fistula also. So because of that, for now, we're recommending an elective cesarean delivery between 37 and 39 weeks, or if a patient goes into labor before that. This is from his publication of the presentation what I just showed you from his presentation in 2022 at our international meeting. This is the publication of that. And this is our first case ever done in the United States. This is on our website, so I can share this. We did our first case December 23rd, 2 days before Christmas in 2020. We had about 3 or 4, probably 5 patients prior to her who we discussed it. A few were not eligible for various reasons, and a couple said, no way, I'm not doing this for the first time ever. So fine. We did ovarian transpositions on those patients. But this was our first, she's actually a nurse in upstate New York. And we had our first baby born 2 months ago. I have not shown the baby's picture just yet because he was in the NICU, he was born a little early, just under 32 weeks. And he just got home, so I didn't want to bother the mom with to ask for permission to show a picture. But we've had our first baby born in the US from this almost 2 months ago. This has been our experience here at MSK. We follow these patients very closely. We are not doing this under an IRB. I can have conversations about that whole IRB issue if anybody's interested, but we're not doing this under an IRB for various reasons. Anyhow, but we're following our patients very close. We've done now 8 patients. The number 7 here is someone who actually had her initial part done in Israel by a friend of mine and a prior fellow of ours, and then wanted her rectal surgery here at MSK. So she came here and we did her reconnection at the time of her low anterior abdominal resection. We've had, of these 8 patients, this 8th patient has a vaginal cancer. Actually, she's currently finishing her radiation therapy in Miami. And we're gonna do a reconnection hopefully in about six weeks or so. So that's why it says TBD. We had 2 patients where where the uterus was not preserved. Our second patient, she was a young patient, 19, very bad cancer, got her radiation. When we went back to try to do her rectal surgery along with her reanastomosis, she had carcinomatosis. It's unfortunate. So at that point, it didn't make sense to save the uterus any longer. We removed the uterus and kept her ovaries. She's passed away already. And this patient here, she delayed treatment. She was seeking alternative therapy. She didn't want to undergo the recommended therapies for her large rectal tumor. She delayed therapy. Finally, those therapies did not work. I mean, she tried other therapies. Those didn't work. The tumor got larger. She came to us. Then she wanted us to do her transposition. A few weeks after the transposition, she presented with a bowel perforation, which happens with rectal tumors. And there was extensive inflammation. It was unclear if the IP had any additional issues with creating a perforation. So I was actually not around and I was away when my partners made a decision to remove her uterus, which I don't have any problem with. And so we have lost 2 uteri in our patients so far. These procedures are often done anywhere from usually within 6 months of their radiation being completed. This one patient had a hard time deciding to proceed with her surgery because it meant a permanent colostomy. She needed an APR, and only she was young, and so but ultimately she agreed to it. So that's why this one was done 13 months later. But ideally, we like to do these within 6 months of completion of the radiation therapy. In terms of functioning of the uterus, again, 2 of our 8 patients. So essentially, we have 8 patients. The 8th patient, we have nothing to say yet about success yet because she's just finishing her radiation therapy now. We've had, of the 7 patients, 2 have had a hysterectomy. So unfortunately, we have not preserved their uteri, but of the other 5 patients, all have resumed menses, and they've all resumed menses within 2 to 4 months of the anastomosis. We've had 2 patients attempt pregnancy, number 3 and number 7. Number 3 is the one that I just told you about. She attempted pregnancy and was pregnant 12 months after her anastomosis. The other patient was pregnant approximately 15 months later. This patient, as I mentioned, she's the one I showed you, had a pregnancy and a delivery at 31 weeks and 2 days. She had preeclampsia, and that's what led to her being sectioned early. And then but the baby's now home, was in the NICU for a bunch of weeks, just went home last week. And this patient is the patient from Israel. I stay in touch with my friend there, and he told me that she did get pregnant on her own. Well, with a partner, I guess, no assisted technologies, but then had an 8-week missed AB. So I'm very excited about this. Again, this is something that's very new. We're learning about it. Many of the things that I've shown are things that we think are helpful, and the inclusion criteria are very selective and conservative at this point. We want to try to have the best success as we can, but as you've seen, this is not something that's successful for everybody. And but I think it's something that will offer a tremendous option for these young women to have children and to have the children without assisted technologies, and also to have a full-term pregnancies, hopefully. Thank you so much, and I'm happy to take as many questions as you all want.
Thank you. Thank you. Thank you so much. Okay. There's one question in the chat regarding the use of anesthesia epidurals in these patients after radiation. Have you seen any challenges with epidural placement? Not from your procedure, obviously, but from the pelvic radiation that they've received when these patients conceive,
So at the time of delivery?
at the time of delivery?
Yeah, so far, no, they've all gotten epidurals for their C-sections, so
Okay, there
no,
was
no
a,
issue, because the radiation is, the radiation fields are far away from where that epidural space. They actually don't affect the vertebral bodies much. They can affect the hips, but normally your epidural is going much higher than the radiation fields to start, and the radiation fields don't go posteriorly as deep to the spinal canal as would be a concern.
okay, thank you.
So far, no, they've all gotten epidurals.
Perfect. One of our
And we
viewers.
also, on top of that, we also do lots of patients who've gotten pelvic radiation. We do the surgeries and we give them epidurals for pain control all the time. That's our standard here, and we do thousands of those. So we've had hundreds, thousands of patients who've had pelvic radiation for lots of reasons. Forget these patients. And then we do their big laparotomies and we give them all routinely epidurals with no problem.
Thank you. Thank you. Thank you. Anyone can come off of mute and ask a question, but you mentioned vaginal delivery because of concern for radiation injury and what that might result in if the patient has a laceration or episiotomy. When you place the uterus back, that is post-radiation. You haven't seen any concerns with the reanastomosis at the cuff.
So far, no, and when you actually, I had to put a picture in this talk of it's like a 6-week post-op. It looks like nothing happened. The cervix looks normal. We actually pull the cervix into the vagina so that it protrudes through, so it's not flush to the top of the vagina. And when you do a speculum exam, like that first patient, I just saw her 2 months ago, you do a speculum exam, it looks like nothing ever happened. It looks like a normal cervix, everything, it's protruding into the vagina. We operate in radiated fields all the time, and it's definitely a challenge when we operate in radiated fields. The thing with radiation therapy is the longer you wait for surgery in a radiated field, that's when the problems become, because you have an onset of fibrosis that starts to really set in months to years later. So it's patients who we've operated on who've been radiated years after the radiation that we have the most challenge of surgery. Normally, when you operate within a few months of radiation, there really is just some edema, but it's not as challenging as it is years later. And most patients who have rectal cancer are getting surgery after radiation anyhow. On top of that, the radiation they're getting is 45 to 50 gray, which is different from like cervical cancer radiation, where you're getting 80 gray to the central pelvis for definitive chemoradiation. So you're getting slightly lower doses than you normally would for like a GYN primary definitive chemoradiation dose of 80 to 85 gray. So far, there is definitely some edema. It's not normal, but we've had no healing issues. We've had no anastomotic breakdowns from the cervical vaginal anastomosis. We had one pelvic collection patient who developed a pelvic collection. It was drained. She did fine, but it wasn't really our issue. It was more from probably the colorectal procedure. So, yeah, again, when you operate in radiated field, it sucks. It's very hard. And the more time has passed from radiation, the harder it gets, just because of the fibrosis that's in from the post-radiation effects. When you do a plan, we oftentimes will do planned surgical resection after radiation. We plan that within 6 to 8 weeks. And so anything within a few months after radiation is generally not as hard as years later.
Perfect. All right, Pasquale.
Yes, thank you very much, Dr. Leitao, for your wonderful talk. And we are here from Miami. I'm here with my fellow Dr. Rodriguez. And there was also Dr. Abed Sinno that he knows you.
Yes.
He just had to leave. He had to go back in the OR.
I thought I saw him pop up on
He said to say hi. Anyway, couple of questions. First one is, are women that have delivered, do they feel the uterine contractions? Because, I don't know if the uterus gets the same reinnervation once it's been put back. When you do the uterus transplant, they don't feel contractions with the pregnant uterus. But do these patients feel contractions?
Well, that's a very good question. My patient was sectioned because of preeclampsia, so she didn't go into labor. The two in Brazil, they were planned C-sections. So that's a very good question. I didn't even think of that. I'd have to ask them. So far, there's only 3 pregnancies in the world that I know of. It's the 2 in Brazil and ours.
Okay.
So again, that's a good
Yeah.
question. I have to
And the
ask my buddy in Brazil if either one of his patients went into labor before having their C-sections, because we want to do plan cesarean deliveries before they go into
Yeah.
labor. So my patient didn't go because she was sectioned because of severe preeclampsia and they had to for that.
Okay. And the second point, it's kind of I would like to know why you say that there is no need of an IRB. Can you briefly say why there is no need of an IRB for someone if they want to start this type of a procedure?
So that's a very philosophical kind of question that we can be here for hours on. First off, what is the question for an IRB? IRB is for
No, the
research.
question for the IRB
No,
is
no.
that is experimental, non-experimental. You have a lot of experience, but if someone wants to start to try such a thing, do they need to come to
So
you? Do they need to go with an IRB? That's what I'm asking.
I know that's a difficult question. If we did IRBs for everything surgical, we have no advancement in surgery. I mean, when we started doing our radical trachelectomies, we just started doing them. We never had an IRB for that. There were people who have done them. We went and saw how they did it. We came back, we discussed it in our group. We got approval from our chiefs and chairs, and we started doing it. If we did everything surgical on an IRB, we would never get anything done surgically. For me, IRBs, and that also, again, this is very philosophical and it depends on your own individual places. For me, an IRB is when you're trying to do research in terms of answering a question about there's a hypothesis, and then you're trying to answer a hypothesis based on statistics. This is so rare that the number of patients, the number of years I would need to answer appropriate IRB protocol would take forever. And we already get hassled every time we open a surgical protocol, and we're not enrolling enough. Second off, we've done lots of things, especially especially in oncology practice, we do lots of things that aren't typical or standard. If we were to do an IRB for every new thing we want to do in oncology, we would never be anywhere in surgical oncology. So that's just a very brief discussion of this. The question when I think of an IRB, it's, what was the research question? What is the hypothesis? What's the alternative hypothesis? How many patients need to enroll, right? So I can't answer any of those questions for this particular thing. The feasibility study, you could do it as a feasibility project, but what's the feasibility question? Can it be done? Yeah, it can be done. I just showed it can be done. So what's the point of IRB? The other thing is, people will assume that because you have an IRB, it's being done more safely. I don't know how much more safely I can do this. I follow my patients closely all the time. I had a discussion before. So what I did is, when I saw Dr. Leitao present this, I'm like, Jesus Christ, I thought about this. So then I come back to my institution and I go over, discuss this closely with my chief. I then presented this all to the colorectal team. So I presented this as soon as I came back from the meeting, a few months later. I discussed with our legal department what we're going to do. I had my chief and my chair of surgery approve it. I then had discussed with the colorectal team, including surgical, medical, radiation oncologist. Every patient at the beginning, and still do, we have a conference call to make sure that they are agreeable to this. Patients are clearly told this is a brand new procedure. I have no idea what the exact outcomes, but compared to a fertility rate and pregnancy rate of 0, it's more than that, hopefully. So that's there's a lot to this. It's a very, very good question.
No,
It's not
but it's
easy
helpful.
answer.
No, it's helpful your answer to try to get away from the IRB also for us.
Yeah. Yeah, I think what you guys do too. I think it's, and on top of that, again, I could talk about this for hours because this took my first procedure was December of 2020. I had seen this presented in March of 2017. I had been discussing and going over this, so basically for 3 years until I did my first procedure here. So this took a lot of thought as to how we would do this. And on top of that, it was a procedure. It's a procedure that is really not that hard to do. We described how we were doing radical trachelectomies with the robot already, which is a much more extensive procedure with more dissection. This is really simpler than that. So there's a lot that went into these thoughts and discussions with my chief, chair, and our legal department here. Yeah.
Thank you
And
very
Dr.
much. Great talk.
Yeah, thank you. Dr. Leitao, so remind me, how is this being paid for? Is it going through?
I don't even know if it's again, I'm the worst to talk about finances because I work at MSK. I'm a faculty that's paid. I get a salary, so I have no idea how anything gets reimbursed. I'm the worst at this. It's good and it's bad. It's bad because I have no idea if I got reimbursed for any of this. It's good because I don't have to worry about that aspect of doing new things. All I know is that we do the procedure. I describe my op, know what's done. Our billers then take care of it. I think they've just been billing as an ovarian transposition, which has a code, or an unlisted laparoscopic procedure, and then we try to justify. I have no idea. So if anyone wants to know how to get reimbursed for this, I am the last person to ask.
But we assume it's being put through insurance.
Yes, it is. That we are getting paid for something.
Okay.
You know, we may be just getting paid for an ovarian transposition, which for me is fine. But it's definitely a more complex situation than just an ovarian transposition. But to me, I believe that's what we're billing for, is an ovarian transposition.
Okay. All right. Well, thank you so much. Are there any other questions before we allow everyone to log off? Well, Dr. Leitao, thank you so much for this talk. It was very informative. Thank you for the videos and your philosophical approach as well to this. We will be in touch again. Have a good day, everybody.
Thanks. And I'm happy to, if anybody wants to email me about anything, just you can share my email with folks if they want.
Okay.